Hello everyone. So we are going with the second subject, that is pharmacology. If you haven't watched the pathology video of EndGame, please kindly go back and watch because we had conducted total 6 hours of classes for pathology, 6.5 hours. Pharmacology our plan is to cover within 6 hours and we will have total of 81 topics. Okay, so we have total 81 topics in pharmacology and this will be divided in 2 videos. Okay, so first video will have total 40 topics and second video will have 41 topics. Okay, so this will be conducted in 2 parts and I wanted to do extra things other than this. This is mainly for pharmacology memorization. Okay, so many students come and ask me, sir, how to memorize pharmac? After reading once or twice, I always forget pharmac. So what to do? So for that purpose, we have created all this image-based visual mnemonics. Okay, so in addition to this, what you need to read is one is PYQs, definitely, because this module doesn't consist of any questions. It consists PYTs, that is previous year related topics. We have total 81 topics. Okay, and second, what you need to do is recent updates. Okay, recent updates, especially in coaching platform, you will have separate heading known as recent updates. Kindly go back and watch it because we have not included very recent updates. Okay, we have included almost everything related to pharmacology from mechanism till side effects, everything. Only recent updates, especially monoclonal antibodies and all, are not included. So these two things are what you'll need to study extra other than this. Okay, so we'll start with the first topic with general pharmacology, which is the most important topic for pharmacology. So we have given importance in this order. First is general pharmaca. Second, we have given importance to ANS. Third priority was antimicrobials, because all these, along with the fourth is CVS. These 4 topics and then fifth CNS. These have almost 90% representation in all pharmac exams, especially in INICET or NEET-PG. That's why our focus will be on these 4 topics and then CNS. Okay, so that is how we will see topic distribution. From GIT, RS, endocrine, only we will have topics on diabetes and rest all will be miscellaneous. Okay, so we are given importance in according to PYQ only. Okay, so first is zero order versus first order kinetics. Okay, so our first topic is zero order versus first order kinetics. Okay, so I'll explain you with the help of image with which it will be easy to remember things. Okay, so this is the overall image we have. So first let us see what is the basic difference between zero order and first order kinetics. Okay, so remember zero as zoo, okay, Z for Z, and first as for fraction. Okay, so what happens in the zoo, you can see here each animal is allowed only at a constant pace. That is, once one animal goes out, only then other animal comes out. So the rate at which these animals are passing, that is the same, it doesn't increase. Whereas in first order, what happens is the rate at which drug is eliminated depends upon how much drug is there in the system. Okay, so in the pizza you can see, like, we are taking 25% always. Okay, so then left, like if we are taking 50%, then only 50% is left. Then again from this we'll take 50%, then only 50% is left. So a constant fraction is taken versus a constant amount is taken. So here it is amount. Okay, a constant amount of drug is eliminated from our body and a constant fraction, that is percentage of drug, is eliminated from the body in first and zero order kinetics. Okay, now what happens to half-life? Half-life means the amount of time taken for the drug to reach half of its concentration. Okay, to reach 50% of its concentration. So in zero order kinetics, what happens? If the drug increases, the rate of elimination is the same. So what should happen now? Now in order, what the body will do? Body will try only elimination of that much amount of drug only. So even if the drug increases in the body, still T half will increase because body will take more time to excrete that drug. Okay, whereas in first order kinetics, no matter how much of a drug is there, that much portion of the drug will be removed out. Okay, so here T half will remain constant. So these are the differences. These are constantly asked in MCQ. Now how to calculate T half in case of first order kinetics? You have formula 0.693, which is a constant, okay, into VD. What is VD? VD is volume of distribution. Okay, volume of distribution divided by CL. CL means clearance. Okay, so if volume of distribution, that is the volume in which the whole body volume in which the drug is distributed, is more, that means the time taken for elimination will also increase. If the clearance is less, maybe the kidneys are not functioning, the kidneys can't excrete the drug, then also the TF will increase. Okay, so this is one formula which you should keep in mind. Only there are 2 formula which you need to keep in mind. So now let's see the difference between first order and zero order and first order kinetics. So you can see here This is the drug concentration available in the body, and body is excreting it at a constant rate. This hole which is there, that doesn't become big. Okay, so even if the drug concentration increases, it will remain the same. So what will happen is the elimination rate, what we are concerned is elimination rate is equal to constant amount, that is whatever the drug is there, okay, divided by how much time it takes. So this is represented by K. So constant amount. Okay, so what is elimination rate? Elimination rate is equal to K in case of zero order kinetics. But what happens in first order kinetics? In first order kinetics, there is a valve, there is a tap, which means if more drug is accumulated, it will take this tap will turn faster, so more amount of water is excreted out of the body, more amount of drug is eliminated. So in the first order kinetics, the rate depends on constant fraction and one more important thing, that is plasma concentration. What is Cp? Cp is plasma concentration. So K is a constant fraction into plasma concentration. This is the equation for first order kinetics. Now if you see the graph of zero order kinetics, no matter how much ever the drug concentration is, Cp is plasma concentration of the drug, it will take that much time to come out. Okay, so the time is constant, that gives us a linear pattern of graph. Okay, but whereas in first order kinetics, what happens is if the drug is more, okay, extra, then there will be exponential decrease. If the drug is 200% means it will metabolize so much amount of drug in a limited amount of time. Okay, so this is an exponential type of curve that you get in first order kinetics. Now what about why this occurs? Okay, let's go to the basics. That is, what happens is in zero order kinetics, there is a toll gate, which means it is a rate limiting step. Okay, which means there is only limited amount until saturation where enzymes can work. Once saturation is done, then the rate will be constant. Okay, so what happens here is there is something known as Vmax. What is Vmax? Vmax is the maximum metabolism rate. You can remember it as if this is a toll gate, what is a maximum capacity at which the toll gate operates? Okay, that is called Vmax. Once this Vmax is reached, then the enzymes are all saturated, then it can't go above that. Okay, so this is the saturation capability of zero order kinetics. Whereas in first order kinetics, there is no toll gate, so traffic can go unlimited. So if more traffic is there, there is so much space to accommodate traffic also. So here it is not saturable, enzymes are abundant, and plasma concentration doesn't depend. Okay, it is very less compared to Km. What is Km? Km is Michaelis-Menten constant. Okay, Michaelis-Menten constant. So Km is indirectly related to the rate, maximum rate at which 50% of the drug is metabolized. Okay, what is the maximum rate at what is the rate at which 50% of the drug is metabolized? Okay, that is called as Michaelis-Menten constant. So the concentration of drug is very less compared to Km. That means the saturability of the enzyme is very less, which means it can have more capacity. It has more capacity to process the substrates. Okay, so it doesn't reach that saturation point. Okay, so this is for first order kinetics. Now, why is zero order kinetics so important? Why NEET NBMS examiners are so fond of asking this question is because what happens in zero order kinetics, when there is constant elimination, if you give more drug concentration, what will happen is it will cause toxicity. So you have 3 drugs important to remember. Okay, how do you remember? The classic mnemonic was 0 watt power. Okay, so 0 for zero order kinetics, W is for warfarin. Okay, warfarin. A is for alcohol. Okay, T is for theophylline, alcohol and aspirin. Okay, T is for theophylline. Okay, and P is for phenytoin. So these 5 drugs, always remember, they are known to cause zero order kinetics, causing, if higher dose is there, then it will cause sudden toxicity. Okay, so in zero, whereas most of the other drugs, they are part of first order kinetics. Okay, so most drugs come under first order kinetics, so they are not much toxic. Now what about clearance? In zero order kinetics, clearance is not proportional to plasma concentration, which means how much ever drug will be there here, the rate at which it is eliminated is always constant. Okay, rate is always constant. Okay, you saw, no, this rate is always constant. Now in first order kinetics, it is proportional to Cp, which means if there is more traffic will go through this gate. Okay, so there is no limit to that. Okay, that's why the T half remains constant in this. Now this is a graph for 2 drugs, so that is, one is phenytoin and one is ethanol. So what happens is, in both cases, whenever concentration of the drug in the plasma is low, it will follow first order kinetics, which means, How much of traffic is there, it will allow. Okay. But once it becomes higher concentration, no, what happens is it will convert to toll gate. So when higher concentration, what happens for phenytoin, which is an anti-epileptic, and ethanol, more amount of drug, like initially you give some amount of drug, plasma concentration is low, nothing will happen, it will get excreted. But once the concentration is reached in high concentration, it will switch to zero order. Now even if you give small concentration of the drug, even if you give small dose, it will immediately cause toxicity. So let's say a patient with the epilepsy was earlier managed with the let's say for example 100 mg of phenytoin. Okay, let's say a pediatric patient with 100 mg of phenytoin patient was managed, but now you increase the dose to 200 mg. So nothing will happen. But suddenly once the saturation occurs, no, like once it converts to zero order, even if you do it to 250 or even 225, then toxicity features will start appearing. Okay, so this is the clinical significance of zero order to first order kinetics, which show both, okay, at higher doses like phenytoin. Okay, so that you should be very careful. Now what happens in ethanol? Same case. Initially alcohol will be processed by this alcohol dehydrogenase enzyme, okay, ADH enzyme. But what happens is later on, what happens after some time is there is saturation of this enzyme. Now this will convert into zero order. Now if you drink alcohol after it is converted into zero order, what happens? It suddenly goes into higher concentration and toxicity will occur. Got my point? So there are two drugs you need to remember. One is phenytoin, one is ethanol or alcohol. Okay, so these two drugs. Now this is the clinical significance. Once you increase the dose, if the enzymes are saturated, if Vmax, that is maximum capacity at which the toll gate is operating, that is our enzyme is operating, is reached, then it leads to toxicity, then it converts into zero order kinetics. Okay, so this is how it is important. Okay, so let's solve the questions. Okay, so go through this table. It's a very concise table. Okay, so examples, what are the examples for zero order kinetics? We have phenytoin and we have one more is alcohol or ethanol. Okay, and then we have aspirin high doses is zero order, just like phenytoin. Okay, now phenytoin shifts from which to which order? So first it is first order, then it converts into zero order. Phenytoin follows mixed kinetics. So first order at what dose? First order at low dose and zero order at higher dose. Now ethanol follows which order kinetics at higher concentration? It follows zero order kinetics at higher concentration. Now there are a few important MCQs which can be asked. See, drug shows constant amount elimination irrespective of plasma concentration. Which metabolism is it? Yes, very good. So no matter how much ever the drug concentration is, the same amount is excreted. So this is first order kinetics. Very good. Now half-life increases with the dose. What is the mechanism? So half-life is not constant. Means if the drug concentration increases, the half-life also increases, which means elimination rate is the same. This is true for zero order kinetics. Very good. Now phenytoin toxicity curve, phenytoin is non-linear, so phenytoin follows zero order kinetics. Okay. Now very important thing is in zero order what happens is it occurs when concentration of the drug is more than Km. Km means it is the half Vmax, means it is the half rate at which maximum drug metabolism occurs. Okay, so 50% of half rate, 50% of our toll gate saturation, that is called Km. If drug concentration is more than that, that means it will follow zero order. If this Vmax, okay, half Vmax, okay, the maximum toll gate capacity is much more than the concentration of the drug, which means the concentration of drug is very minute compared to this one, means there are so many enzymes available. So even to reach this half Vmax, it takes so much drug concentration, okay, then it follows first order kinetics. I hope now you guys don't have any confusion. Okay, so zero order drug causes sudden toxicity with small dose increase. So zero order rate is what? Rate is always constant, which is K. We denote it as K0. Okay. In first order, rate is equal to K into what? Cp. Cp means plasma concentration. So if plasma concentration is increased, elimination rate is increased. You saw it here, right? See here. See this. If drug concentration is increased, our rate is also increased. Okay. So K into Cp. So I think we are clear about this. No more doubts. So let's go to the second topic, that is half-life, loading dose and maintaining dose. So let's go into next concept, that is T-half, loading dose and maintenance dose. This is also again a concept based topic. So give proper attention and listen to this. Okay. So what is loading dose and maintenance dose? How do you memorize it, or how do you understand it? See, loading dose is like filling the empty petrol tank, okay? So we have 0 petrol and you want to fill it, otherwise you can't start your vehicle, right? Now if you want a full tank. So doing this, filling the tank, is known as loading dose, okay? So that means your body doesn't has any drug. Initially you have to give some drug to show some rapid effect. Why? I'll tell you later. What is maintenance dose? Maintenance dose means once it is full tank, after that car will run, right? During that, petrol will decrease. So now you will have to give some petrol so that this car, this tank is always full. So as the car runs like 10 km, we'll have to give some like maybe 1 liter of petrol, okay? So that is known as maintenance dose, okay? So that concept is clear now. Now, why do we have to give this loading dose for some of the drugs? See, loading dose is given when you want a immediate effect, like you want to reach that concentration very quickly. There you give loading dose. What happens is, when a drug is there in the system, no, like once you give some amount of drug, let's say like 650 mg of paracetamol, okay? Now initially that drug will reach some plasma concentration which is not 100%, okay? Then that is during first half of T half, okay, the concentration of the drug is only this much, okay? Then during second T half it will reach here, third T half it will reach here. So there will be a point where your filling petrol, okay, that is maintenance dose, and the car is using, both should be equal, okay? So that time only this tank will be steady. So that is known as steady state concentration. To reach this steady state concentration, which is CSS, it will take approximately 4 to 5 T half. Got it? Now you will have to give this drug 3 or 4 times to reach this steady state of concentration. So instead of that, what you give? You give loading dose. Loading dose, what will happen is, immediately you give 1 dose, it will reach the steady state concentration, or a concentration where you find a desirable effect, okay? So this is the concept of loading dose and maintenance dose. Now what happens to half-life and steady state concentration? Say initially you give some 100 amount of drug, okay, 100%, let's say 650 mg of paracetamol, or let's say 500 mg. Now what happens after first T half of paracetamol? How much drug is left in our body? It is only 250 mg. Then after that, after second half life, how much is left? 125. Then how much is left? The half of this, okay, that is 62.5, okay? So this is how the normal kinetics happen in the body, okay? So this T half depends on 2 factors. One is volume of distribution. Volume of distribution means the total body volume. It is not exactly the total body volume. It depends on whether the drug is confined to the vascular system only. If the drug only goes to the blood, that means it has lower volume of distribution. But if it goes to the blood also, tissue also, it goes into the intercellular space also, then it will have higher volume of distribution, okay? So that depends on, one is volume of distribution, this T half. Second is what is the rate at which it is eliminated out, that is known as clearance. So T half depends on what? 2 things, okay? T half depends on, one is volume of distribution, second is the clearance rate at which the drug is put out of the body. VD is the rate at which, the volume in which it gets distributed, okay? So this, when we remove this proportion, we'll get a constant that is 0.693. So this is the formula for T half. This you shouldn't forget, okay? Now what happens in loading dose and maintenance dose is, in loading dose you give a rapid bolus, okay, so that this drug is distributed in the whole volume of distribution whichever is available, okay? So what is the formula for loading dose? It is VD, because it depends on how much volume the body has to distribute this drug into what is the target plasma concentration we require, divided by bioavailability. So what is bioavailability? Bioavailability is when you give drug through a route, maybe through subcutaneous route or oral route or IV route or IM route, what is the concentration that actually reaches the blood? That is known as bioavailability, okay? So now this bioavailability for subcutaneous, oral and all is less than 100%, because not everything what you give from oral will reach the blood, right? Because there is something called as first pass metabolism, okay, first pass metabolism. But in IV route, all 100% drug reaches the blood, okay? So that's why in IV route, bioavailability, which is represented by F, is equal to 1. 1 means 100%, okay? So you can see here, bioavailability of oral is less than 1 and IV is 1. So for loading dose for an IV formulation becomes what? It is equal to volume of distribution into target CP divided by F, but we know that bioavailability, that is F, is equal to 1. So the formula for loading dose in IV for an IV formulation is volume of distribution into target plasma concentration. Okay, if it is oral, then it will change because the F value doesn't become 1, it becomes less than 1. Okay, now what happens in loading doses? One important thing you should know is loading dose depends on what I said. It depends on volume of distribution. It doesn't depend on anything else. It doesn't depend on clearance. It just depends on how much amount is there for the drug to distribute. Okay, so this volume is based on this volume of distribution gives us the loading dose. So even if there is renal disease, the loading dose remains unchanged. Remember it. Okay, remember it. In renal failure and all, volume of distribution will be same only. There is no difference. Volume of distribution doesn't change in renal disease, and hence loading dose doesn't change for acute renal failure or chronic renal failure. Okay, this thing you will have to keep in mind. Now, what is maintenance dose? Maintenance dose is that extra fuel you need to add on because our car burns some fuel. It burns petrol, right? So now it depends on how much the car is burning petrol. So that means it depends on clearance. So what is clearance? How much kidney is putting out the drug, okay, eliminating the drug, or how much our liver is eliminating the drug. So maintenance dose depends on what? It depends on clearance, and rest of the formula is the same. Okay, no change in the formula. It is the same as loading dose, but now it depends on clearance. Okay, so that's why now, yes, you have got it right. So maintenance dose, okay, it depends on clearance. So in hepatic failure or in renal failure, where there is decreased clearance, what happens to maintenance dose? Maintenance dose should decrease. Got my point? This is known as renal adjusted dose. We commonly come across, whenever you might have seen during your internship and all, we in kidney failure patients, AKI or in CKD, we give something known as renal adjusted dose, which means the maintenance capacity of the kidney is lost. It can't excrete that much amount of drug, so we decrease the amount of drug, but loading dose remains unchanged. Okay, so let's solve the questions. I hope everything is clear by now. Okay, so what is half-life? Half-life is equal to 0.693 into volume of distribution divided by clearance. No doubt in that. Okay, loading dose is equal to VD, volume of distribution, into this thing remains the same. Okay, for loading dose and maintenance dose. Now MCQ, loading dose, it depends. We need rapid levels. Whenever we want rapid levels, this is commonly given, for example, for anti-epileptic drugs. Let's say we say no, like immediately the patient comes in status epilepticus, give phenytoin loading dose. So phenytoin loading dose is 20 mg per kg, followed by maintenance dose is 10 mg per kg. So this is what is called loading dose. Okay, so loading dose we want for rapid, like getting rapid levels of the drug. Okay, maintenance dose, what is the formula? Clearance into plasma concentration divided by bioavailability. Okay, next, clearance. What is the formula for clearance? Clearance is equal to rate of elimination divided by plasma concentration. Okay, and this depends on what? This depends on renal and hepatic function. Okay, renal and hepatic function. So if your creatinine is more in a question, that means your clearance will become less. Got it? Next, steady state. So rate in is equal to rate out. I told you after 4 to 5 half-lives, 4 to 5 T half, the rate at which we are giving the drug inside is equal to rate out. Okay, that is the car fuel, whichever, how much ever it is burning, becomes equal to whatever we are filling for the tank. That takes 4 to 5 T half. Okay, now in renal failure there is lower maintenance dose, but loading dose remains the same. Okay, changing dash does not change T half. This is for first order kinetics. See, in first order kinetics, if you change dose, it doesn't affect T half. T half will be constant because constant fraction is eliminated in that given amount of time. Okay, so I think rest of the things you go through, I think I have explained everything. Okay, one more important thing I want to focus is, I told you like maintenance dose depends on renal and hepatic function. Okay, that is clearance. Now what does loading dose depend on? It depends on volume of distribution. So can you tell me one condition where volume of distribution changes? Yes, for example, there is ascites. In ascites, what happens? There is increased accumulation of fluid. That is, volume will increase in the ascitic fluid. Okay, the ascitic fluid volume will increase. So here loading dose will change. Okay, so LD usually is unchanged unless the VD is altered. For example, in ascites. Okay, so we'll go to next topic now, that is volume of distribution. We'll see in depth. Okay, so core concept on volume of distribution. Okay, so I told you in the previous slide what is volume of distribution. So volume of distribution doesn't only depend on how much this human being volume is. Okay, this is not only this much, it also depends on wherever the drug goes. Okay, so if it goes and binds to the skeletal muscles and the adipose tissue and all, then volume of distribution is higher. If it stays only in the blood vessels, only in the blood, it doesn't go into the tissues, then the volume is lower, because only blood volume is less, but blood volume plus tissue volume will be more, right? And along with that, if there is something called ascites or if there is any edema, then drug can go there also. So then volume of distribution increases. So volume of distribution is not anatomical volume, it's a theoretical volume where all drug can go. Okay, now see what is you should know two things here. One is what are plasma bound drugs. Plasma bound drugs means inside the blood vessel there will be albumin, right? Plasma proteins. So drugs are bound to those plasma proteins. Okay, so these are plasma proteins, albumin, especially albumin. Okay, so whenever albumin levels fluctuate, it increases or decreases, this drug whichever is available in the blood, that increases or decreases. Okay, similarly there is something called as tissue bound drugs. For example, digoxin is best example for this, which goes into the tissue, into the muscles, into the adipose tissue and all, and then it gets accumulated drug. These are especially lipophilic drugs. Okay, so you should know that if it is only plasma bound drug, which means it remains within the blood vessel, it has smaller volume of distribution. If it goes into the tissues and all and into the muscles and all, it has larger volume of distribution. So what becomes to the formula? What will be the formula of volume of distribution? See, volume of distribution, it is equal to amount of drug in the body. Okay, total how much of a drug is there in the body. Okay, amount of drug in the body. Okay, amount of drug in the body divided by plasma concentration. This is the formula for volume of distribution. Okay, again tell me what is the formula for loading dose. Loading dose is equal to, yes, very good, volume of distribution into, yes, into plasma concentration divided by bioavailability. What is the formula for maintenance dose? Yes, very good, it is clearance into plasma concentration divided by bioavailability. What about T half? Yes, T half is dependent on volume of distribution and clearance. So T half is equal to 0.693 into Vd by Cl. So these are the only four formula you need to remember in pharmacokinetics. Okay, now here with some concentration. Okay, so whenever a drug has low volume of distribution, which we mean that there is less than 10 liter of volume that in which drug can suspend itself. Okay, so volume of distribution is nothing but it is how much diluted the drug is in the system. Okay, so low volume of dilution means in the whole body it is only present in the blood vessels, nothing, nowhere else. Okay, so that means it is highly protein bound, and hence since it is albumin bound, so the albumin doesn't allow the drug to go anywhere else. Got my point? In this case, if albumin decreases, then what happens? More free drug is available. Okay, now this more free drug can cause increased toxicity. Got my point? Okay, so this is one thing which you need to remember. Now there are second category of drugs which are medium volume of distribution between 20 to 40 liters. Here these drugs are hydrophilic drugs, which means it can go into the extracellular space, that is from the blood vessel it can go in between the cells. Okay, in extracellular space. Okay, so these are slightly higher volume of distribution. And then third category we have, which are lipophilic drugs, which means which have affinity towards adipose tissue and muscles. So it will go out of the blood compartment, out of the extracellular fluid, and it will go into the cells, into the adipose tissue and all, and into the muscles. So this will have very high volume of distribution. And you are right, when volume of distribution is high, it will take more time for this drug to get excreted. So their T half is also higher. Okay, so that is simple logic. Now what happens with plasma protein? If there is normal albumin, volume of distribution is low because all the drug will remain in the blood compartment only. Now if there is hypoalbuminemia, as occurs in burns, what will happen? There are more free drugs. This free drug can go into any other space also, so volume of distribution increases. So there is increased fraction of the drug, increased apparent volume of distribution, and there is increased toxicity risk. Okay, now in obese patients what happens? More adipose tissue, so more volume of distribution is there. Remember? Okay, similarly in edema, let's say in ascites, or let's say in liver failure, okay, or let's say nephrotic syndrome, what happens? There is more water in the body. Okay, edema is more, so what happens? For hydrophilic drugs, volume of distribution is higher. Okay, Now, there are some important things. I told you what is the formula for loading dose. See, loading dose depends on volume of distribution. So, in obesity, what happens? We know that volume of distribution is higher because there is more adipose tissue. So, what happens? These patients require higher loading dose for lipophilic drugs. Okay, for lipophilic drugs, obese patients require higher loading dose. I hope this concept is clear. Second concept. Higher volume of distribution means most of the drug where it is in the tissues, it is in the muscles, it is in the extracellular space. So it is not in the blood. So hemodialysis is not useful for drugs with higher volume of distribution because they are inside tissue, they are inside muscles. Okay. So higher volume of distribution means longer half-life. Okay. So we'll go to the questions now. I hope everything is clear in this. I have made it very simple for you guys. Okay. Now, if it is less than 10 liter, drug stays in the plasma, so this is low volume of distribution. If medium volume of distribution, then distributes in extracellular fluid, this is hydrophilic drugs. And in lipophilic drugs, there is high volume of distribution, so this goes into the tissues. Now, next thing, for obesity, volume of distribution is increased, so there will be increased loading dose for lipophilic drugs. In burns, protein will decrease. So if protein decreases, what happens? There will be increased free drug available, which means there is higher volume of distribution in burns. In edema also there is higher volume of distribution. Now DASH drugs have low volume of distribution, that is protein bound drugs. Okay, protein bound drugs have low volume of distribution. Next, formula for VD. What is the formula for VD? I told you volume of distribution depends on amount of drug on the body. Okay, amount of drug divided by plasma concentration. Okay, so it is nothing but how much diluted the drug is in the system, in the body. What increases VD? I told, if decreased protein, then that increases VD, or if there is increased adipose tissue or in obesity, that increases VD. Okay, and in conditions like burns, ascites, okay, and in nephrotic syndrome, in all these cases we have lower protein, so that increases VD. Which drugs have lower VD? Protein bound drugs have lower VD. Okay, next, hypoalbuminemia, increased free fraction of the drug, increased apparent volume of distribution leads to toxicity of certain drugs. Okay, not all drugs. Okay, so I guess volume of distribution is explained clearly to you guys. So next we'll go to routes of administration, a simple topic. Next topic is routes of drug administration, a simple topic, yet you shouldn't lose marks in this topic. Okay, so which are the various type of admission? It is either enteral or parenteral. Okay, so there are only two types, enteral and parenteral. Okay, so enteral route means it is either oral, that is per oral, like for example any drug which you take shouldn't undergo degradation by gastric acid. It will have slower onset after 30 to 90 minutes, and it will undergo, important thing is first pass metabolism. So liver metabolizes one fraction of the drug. So this is the disadvantage of oral route actually. So bioavailability is always less than 100%. Second is sublingual route. There is advantage for this. One is it is rapid, it has very rapid onset, and second is the drug directly goes into systemic circulation from the lingual blood vessels. Okay, so sublingual route is used in emergency cases. For example, for hypertension, okay, hypertension urgency, emergency, we give sublingual antihypertensives like nifedipine. Okay, also we give sublingual nitroglycerin in cases of ischemic heart disease. Okay, so for rapid onset and for direct systemic circulation, sublingual is preferred. Third is per rectal. Now the important thing is there is many of you will think that through rectal route there is no first pass metabolism, which is actually wrong. Because in rectal route, there are three type of veins. One is upper rectal vein, second is middle and lower rectal veins. Okay, from these rectal veins absorption takes place. So from middle and lower rectal vein, it will directly go into systemic circulation. So no first pass metabolism. But in upper rectal vein, there it goes to portal vein and then it undergoes first pass metabolism. Okay, so here first pass metabolism will be there. So there won't be 100% bioavailability in case of rectal route. Okay, so it is partial first pass metabolism in rectal route. Okay, so bioavailability, if you consider overall, oral is the lowest among bioavailability. Okay, next parenteral route, it can be either IV, it can be IM or by subcutaneous route. Okay, so IV route, it has very rapid onset, there is 100% availability, and you can dose precise, means there is no first pass metabolism, and also whatever you are giving directly goes into the blood. Intramuscular route has fast onset, okay, but not as fast as IV, and it has moderate bioavailability because something remains in the muscle only, not everything gets absorbed. And third is subcutaneous, where onset is very slow. Example is insulin, subcutaneous insulin that we give. And fourth is intradermal, okay, for example BCG skin test which we give, okay. So all these are intradermal type of this one, okay. All these are parenteral routes of administration. Now, what is a clinical correlation? One is gastric enzyme should not be able to degrade these drugs, okay, through when it is given through oral route. Next, rectal diazepam is given in case of seizures, because you won't sometimes get IV route, so because it is difficult in a seizing person to insert cannula, so rectal diazepam is given in seizures. Next, sublingual nitrates and sublingual nifedipine I told in case of MI and angina, and in case of hypertensive urgencies. And next is transdermal patch also, okay. So there is local effect for this and there is systemic effect for this. Then there are some important exam mistakes that you make. One is rectal is not 100% bypass, okay. It doesn't bypass first pass metabolism, I told you earlier, okay. Second is subcutaneous route never choose in case of shock and all, okay. In shock we don't use subcutaneous route and all, okay. Third is IV is safer, more safe, but there is only one risk, that is risk of embolism and infection, okay. So it is not very safe also IV. And fourth, transdermal gives not only local effect, it also gives systemic effect, because slowly in a long term basis the drug gets absorbed into systemic circulation also, okay. So we'll go into the questions, okay. There are some important concepts to clear also among the questions. So onset, okay, parental route is rapid onset, okay, it is rapid onset. Next, first pass metabolism is absent in parental and it is present in enteral route, okay. Next, accuracy, this is predictable actually. Which one? IV route, okay. IV route is predictable, this has variable absorption. Safety wise, enteral route is safer, because in IV route, IM route, parental route, we have risk of infection. Examples for oral route are oral, rectal, and one more we have sublingual, okay. Bioavailability is 100% in case of IV, okay. In case of IM and SC, it is less than 100%. This is simply waste, simply it was by mistake, okay. Next, rectal route completely avoids first pass metabolism is actually false. It doesn't completely avoid. IV routes are always safe is also false, because there can be risk of embolism and there can be risk of infection, okay. Thrombophlebitis and all can occur. Subcutaneous route is contraindicated in shock, which is true. Next, route bypassing first pass metabolism among oral routes is sublingual route, okay, among enteral routes, okay, not oral. Rapid onset, you have to give IV, okay. BCG test route, BCG test is done via intradermal, okay, that is MAN2 test, okay, MAN2, and also BCG vaccination, both are given via intradermal route. Next, dash is directly given to liver. What is this intra-arterial? See, what happens is in case of hepatic tumors, okay, liver tumors, these liver tumors are fed by hepatic artery, okay, but normal liver cells, no, they will be through hepatic vein, okay. So if you give drug through intradermal route, what will happen is it will come through venous route, no? So it will go only through hepatic veins. Normal cells will also be affected. But in this case, what we'll do is through femoral artery, we'll insert a catheter and into the hepatic arteries, so that this hepatic artery drug through the hepatic artery goes into these tumors, because tumors are mainly dependent on hepatic artery rather than hepatic vein. So it will selectively kill the tumors, okay. So this intra-arterial route is directly to liver. It is used in case of chemotherapy for liver tumors, okay. Okay, I think I have answered everything, okay. Insulin is not given orally because it is destroyed by gastric enzymes, okay. So that is the ultimate necessity. If you are giving away oral route, it shouldn't be destroyed by gastric enzymes, okay. So rectal sublingual is useful in seizures and sublingual nitrate for relieving angina rapidly. So we'll go to next topic from pharmacokinetics. Now we'll be going to pharmacodynamics, okay. Okay, now we are moving towards pharmacodynamics, okay. So we have seen so far pharmacokinetics. In this first we'll go through two different reactions under pharmacodynamics, that is under drug metabolism, phase 1 and phase 2 reactions, okay. So what is this phase 1 and phase 2? Basically, once the drug enters the body, what happens with the drug? That is called pharmacodynamics. Okay. So this drug can undergo certain reactions under phase 1 and get converted into something different. Like for example, a pro-drug gets converted to active drug. Okay. So that is what is happening in phase 1. Or maybe the drug gets inactivated also. Okay. Or some groups are added, some groups are lost. That happens in phase 1. Okay. So phase 1 is basically functionalization of that particular drug. Okay. So phase 1 reactions, it can be either oxidation, it can be reduction, it can be hydrolysis. Okay. So these three main components you should remember: oxidation, hydrolysis and reduction. And this phase, especially oxidation, is mediated by this CYP450. Okay, CYP means cytochrome P450. This is the main enzyme present, especially in the liver. Okay, that is cytosol. So this actually determines all these reactions of the drugs. Okay, so that's why you'll find all CYP inhibitors and all. In that, most important is CYP450. Okay, in phase 2, what happens is there is like once the drug is active or inactive, then it should be excreted, right? So it should be made more water soluble. So that part is for phase 2. In phase 2, what happens is, see, here is phase 2. There are three processes mainly. One is glucuronidation, sulfation and acetylation. What happens is, to this drug, either glucuronic acid is added or sulfate is added or acetyl group is added, so that it becomes easy to excrete from the body. Okay, so these are phase 1 and phase 2. You should know which groups, which reactions come under which phases. Now this cytochrome P450, which I told, cytochrome enzyme, these are mainly involved in drug interactions. So drug interaction can be some drug which can inhibit other drugs activity. Those are known as enzyme inhibitors, which means there are some drugs. For example, you see here enzyme inhibitors, macrolides, azoles, which are antifungals, isoniazid. All this, what they do, they will inhibit the cytochrome P450. Okay, cytochrome enzymes. They will lead to breakdown of this enzyme. So as a result of which, what will happen? Drug will not be metabolized and drug concentration will increase in the blood. Okay, so they are inhibitors of the enzyme, as a result of which drug is not metabolized. So that leads to drug toxicity. So remember, enzyme inhibitors lead to other drug toxicities, whereas enzyme inducer, there are some drugs like rifampicin, phenytoin, carbamazepine. Okay, remember like this: rifampicin is ATT, phenytoin is anti-epileptic drug, and carbamazepine is also anti-epileptic drug. What they do, they will induce the enzyme, which in turn breaks down this drug, so there is faster metabolism and decreased activity of the drug. Okay, so this actually decreases. For example, classic example which we see is a patient on antitubercular therapy, ATT, okay, which contains rifampicin. The patient is also on OCP, leads to OCP failure, because this rifampicin induces CYP enzymes which break down OCP, resulting in decreased action of OCP, leading to OCP failure and hence pregnancy. Okay, so this is how questions will be framed for you. Now there are something known as slow acetylators, which comes in respect to a drug called isoniazid. You know that isoniazid is enzyme inhibitor. Okay, enzyme inhibitor. Now this inhibits certain enzymes, but there are some people who have slow acetylation reaction. Now this isoniazid is excreted via acetylation. Okay, so there are some people with genetic polymorphisms with who excrete this, in whom acetylation is delayed, as a result of which more INH accumulate, and this leads to INH toxicity. And in further videos, in the further part of the video, we'll see INH toxicity leads to hepatotoxicity. Okay, it is known as ATT induced hepatitis. Okay, ATT induced hepatitis, and if it is not associated given along with B6, then it can lead to peripheral neuropathy. That's why we always supplement isoniazid with vitamin B6. Okay, now in neonates, what happens is what is this glucuronidation? Glucuronidation is mediated by this uridyl glucuronyl transferase enzyme. Okay, UGT. Now in neonates, what happens? This enzyme is not active, hence bilirubin. Okay, one is bilirubin. Okay, bilirubin doesn't get metabolized. That is the reason for neonatal jaundice. Also, some drugs which are given during neonatal period, maybe some antibiotics or some anti-epileptics, they are also not metabolized because this glucuronidation is not taking place. Hence, they are not excreted. Okay, as a result, it can lead to toxicity. Okay, it can lead to toxicity of that particular drug, especially in the neonatal period. Now, what happens in case of liver disease? In liver disease, remember, phase 1 is affected more than phase 2. Now, you will ask me why phase 1 is affected? Because cytochrome 450, okay, cytochrome P450, which is there, it is mainly present in the liver, okay. So, whenever this cytochrome P450 is involved, then in the liver, some like maybe some stress induced or maybe some insult happens. In that case, phase 1 is affected more than phase 2, okay. Now, some drugs, they will directly bypass phase 1 and directly enter phase 2, and example for that is morphine. So, in your exam, your question will be, all of the following drugs will have phase 2 metabolism, will skip phase 1 except, will go through phase 1 to phase 2 except, which one will skip? Answer is morphine, okay. So, now we'll go to the question answer session. So, phase 1, oxidation, reduction, hydrolysis, and it is mediated by, oxidation is mediated by which cytochrome? Cytochrome P450. Phase 2, which are the enzymes? Glucuronidation, sulfation, and acetylation. CYP inducers, rifampicin, phenytoin, I told you, two anti-epileptic drugs, phenytoin and carbamazepine. CYP inhibitors are macrolides, azoles, and one more is INH, isoniazid, okay, very important antitubercular drug. Slow acetylators are seen in which drug? INH, and it leads to INH toxicity. Alcohol competitively inhibits which enzyme? It inhibits alcohol dehydrogenase enzyme, okay, and it inhibits which CYP? CYP, yes, very good, CYP2E1, okay, CYP2E1. Next, phase 1 is known as functionalized. So, we are functionalizing the drug, okay. Okay, so along with this, we'll go to the next part, that is enzyme inducers and enzyme inhibition. Why I'm stressing so much on pharmacokinetics and pharmacodynamics? Because many questions are being asked from this topic. Okay, next topic is enzyme inducers and inhibitors. Again, a very important topic which will be going in depth, okay. So what are these enzymes? These are nothing but CYP, that is cytochrome P enzymes. Okay, there are various types of CYPs. Most common we have seen CYP 450 is the most common enzyme that is involved in drug metabolism, okay. So what happens, there are some drugs which are enzyme inducers, means drug A induces metabolism of drug B by induction of CYP enzymes. Okay, that is the meaning of it. Okay, that you have to understand. Okay, the drug itself doesn't cause inhibition of its own or induction of its own metabolism. It is one drug causing induction of metabolism of another drug. Okay, so what happens is this enzyme inducer. There are some drugs which are enzyme inducers which induces metabolism of other drugs. Okay, so what these drugs do is enzyme inducers, they'll act on the liver, mainly liver. Okay, in the liver cytosol, in the liver nucleus, it will cause some mRNA, some changes. It will cause increased synthesis of this CYP, okay, cytochrome enzymes, and these cytochrome enzymes, it will take some time to synthesize, right? So this is a gradual slow process, and finally cytochrome enzymes are processed, and then these cause metabolism of drug B. Okay, so what will happen because of this? The drug which is there in the system is broken down by this, metabolized by this enzyme, and as a result there is lesser concentration of drug in the body, and that leads to therapeutic failure. What is area under the curve? We'll come to it later on. Okay, so example of this is OCP. Okay, so there are some drugs like rifampicin. Rifampicin is an enzyme inducer. Now rifampicin induces cytochrome enzymes which inhibit action of OCP, that is OCP drugs, that is estrogen and progesterone. They are broken down quickly and hence leads to OCP failure. Okay, so this is an example of enzyme inducer. Now there are some drugs which are enzyme inhibitors, which means when the drug acts, say like this inhibitor drug, what it does, these inhibitor drugs, they will cause inhibition of this enzyme, as a result of which the original drug, A drug, okay, A drug which was supposed to act on the body is not metabolized in the liver. Hence this A drug concentration increases because this B drug is causing inhibition of this enzymes which cause breakdown of this drug A. As a result, increase in concentration of drug A causes what? It causes toxicity, and this effect is immediate. It is competitive or non-competitive type of block also, whichever type of block that enzyme, that particular drug does on the enzyme. Okay, so now what happens to the plasma level of the enzyme? Because this drug B is inhibiting these enzymes, the level of drug A increases because there is no one to metabolize these enzymes. As a result, it leads to toxicity. Example is warfarin, which we will be seeing in the coming video. Okay, so now what are the example for enzyme inducers? You'll have to remember certain with the mnemonic known as PS porks. Okay, so phenytoin, smoking, phenobarbital, rifampicin, carbamazepine, and St. John's wort. Okay, so these do something, memorize this thing, okay, because this is a frequently asked question and you tend to mistake this in your exam every time, okay, and these are the reasons why you make silly mistake. PS pox, okay, phenytoin, then smoking, phenobarbital, rifampicin, C is for carbamazepine, and S is for St. John's wort. Okay, don't forget it. Similarly, for enzyme inhibitors, remember these 4 or 5 drugs. One is valproate. Okay, there it was phenytoin, here it is valproate. There it was rifampicin, and here it is INH. Okay, so INH comes here only. Okay, this I is for INH. Okay, INH, that is isoniazid. Okay, similarly, fluconazole. Then remember ciprofloxacin. Remember cimetidine, alcohol, erythromycin. Remember at least these drugs. Okay, so the mnemonic is sickfaces.com. Remember at least these 4-5 drugs which I mentioned. Okay, now we'll see example. What happens in when there is enzyme inhibitor, so sorry, enzyme inducer. When enzyme inducer is there, the therapeutic level of drug A, which was supposed to act, comes down because enzymes are induced. So those enzymes will metabolize drug A. Hence, what will happen is it will lead to lower AUC, which means lower area under the curve. So there is decreased effect of drug A. Okay. What happens in enzyme inhibition? You know that as here you can say, as in enzyme inhibition, drug A levels increase. As a result, there is higher area under the curve, which is nothing but bioavailability, and hence it can lead to toxicity. Okay. So some examples which you need to know: grapefruit juice. Okay, grapefruit juice inhibit this enzyme CYP3A4. Okay, this is an important enzyme. Next, smoking induces which enzyme? CYP1A2. Okay, A2 is for smoking, A4, 3A4 is for grape juice. Okay, now there is something known as auto-induction, which means some drug induces an enzyme. Okay, drug A induces some cytochrome enzyme, which then metabolizes the same drug. Okay, this is seen in case of carbamazepine. Okay, this is classical example of carbamazepine. Okay, some other examples are when rifampicin is taken along with OCP. Let's say your question will be: a patient who is on ATT, a female who is on antitubercular therapy, was prescribed OCP, but there was reason for OCP failure. What is the reason for this? Like what actually happened in this case? So what happened? Rifampicin caused enzyme induction. Okay, it caused enzyme induction, which broke down OCP, as a result of which OCP got failed. Next, a patient of stroke was prescribed warfarin, but because of then he had some infection, let's say some pneumonia type, for which erythromycin was given, and then there was bleeding episode. What is the reason for this? Simple. Erythromycin is an enzyme inhibitor. So when warfarin is inhibited, INR will increase. Okay, so that leads to bleeding episodes. Next, third, isoniazid. Isoniazid, I told it is an enzyme inhibitor. Remember this. Acute alcohol. See, alcohol, there are 2 types. Chronic alcoholism causes enzyme induction. Acute alcohol causes enzyme inhibition. Okay, so these things you need to remember, and let's go to the question answer session. So what is the mechanism of core mechanism behind enzyme induces? It is increased CYP enzyme activity. Okay, that is increased CYP enzyme synthesis. Next, effect on drug. What happens in enzyme inhibition? The drug level increases. Duration. CYP, I told you, in enzyme induces, it will take some time for cytochrome P to synthesize, so that's why it is a slow process. Okay, clearance of the drug in enzyme induces. What happens? Clearance of the drug is increased. Next, what happens to area under curve? Area under curve is increased in case of enzyme inhibition. What is the clinical clue in this? Failure of therapy. Okay, failure of therapy is the clue. Like for example, I told you OCP and rifampicin, failure of OCP. Smoking induces CYP1A8. Actually, this is involved in metabolism of theophylline. So that's why theophylline levels will decrease if smoking is also present. Okay. Isoniazid acts as enzyme inhibitor. Acute alcohol acts as enzyme inhibitor. Okay, so there are some important things I want to focus you also. One is St. John's wort. It also acts on CYP3A4. Okay, CYP3A4 leads to OCP failure. Okay, this is one thing you need to remember. Second, chronic alcoholic is an inducer, whereas acute alcohol toxicity is an inhibitor. Okay, now macrolides inhibit warfarin, which we have already discussed. Okay, and yes, I think I have discussed almost everything. Okay, so let's go to next topic. That is competitive versus non-competitive inhibition. A topic which is very frequently mistaken by students. in pharmacology is competitive versus non-competitive. Again, this topic is again repeated in biochemistry also. There also students very frequently make mistake in this despite knowing everything about it. So I have given a visual mnemonic which you will never forget, okay, in your lifetime. So remember, basic things we'll see first, okay. See what is competitive and what is non-competitive. Competitive means if this is the enzyme substrate binding site, this is the substrate and this is the enzyme, okay. So this substrate is supposed to bind here, but there is some other compound which binds to the same site, this inhibitor, okay. If the same site is used, then it is competitive because the inhibitor is competing along with the substrate. But whereas if the drug or if any inhibitor binds at different site, then it changes the active site, like the shape is changed, okay. It was supposed to be like this, but now the shape has changed, okay. But this inhibitor doesn't bind to this side, it binds to some other allosteric side, then it is known as non-competitive. This basic concept everyone knows. Now the next frequently asked question is what happens to Vmax and what happens to Km in case of competitive inhibition and non-competitive inhibition, okay. This is what we are going to say, and this is where students often commit mistake, okay. So remember competitive as a and non-competitive inhibition as a race, okay. So you have some vehicle which is actually better than other vehicles, okay. So this is imagine this is a inhibitor, okay. These are the inhibitors, sorry, okay. These are the inhibitors, okay. So these red colored are the inhibitors. So you are seeing here now, these are the inhibitors and these rest are the like substrates, okay. So what happens here is the cars which are there, this inhibitor, it is similar to other cars, okay. That is the other substrate, okay. So it is similar in structure and similar in composition to the substrate, okay, these inhibitors, okay. So now what happens, since these have similar structure to the car, their speed, okay, their speed will remain the same, okay, as simple as that. So in competitive, structure of the enzymes are structure of the substrate and the inhibitors are the same. So if the car is of same model, the car is of same type and all, the speed should remain the same, correct, the maximum speed. So Vmax remains same, okay. So same Vmax is for competitive inhibition, no doubt in that, okay. Now what happens, this is how you remember Vmax, okay. Now what happens in case of non-competitive, this car is something different, okay. It is something different. It is like it is bigger, the model is different, but this car has a defect. It has a defect that is allosteric brake, okay. So that means its speed is less compared to other cars, okay. So that means what happens, Vmax is decreased in non-competitive inhibition and Vmax is remains the same, okay, in competitive inhibition, okay. Now coming to Km, okay, Km is what? Km is substrate, okay. So substrate means if suppose more fuel or more efficient fuel is given to this same vehicle, what will happen? It will easily overcome, right? So this fuel is nothing but substrate, okay. This fuel is nothing but Km or substrate. So increasing fuel or increasing the mileage of these vehicles, or sorry, increasing the speed efficiency of these vehicles, any of these vehicles can actually overcome can actually overcome the ability of the substrate, okay. Sorry, they can actually overcome the ability of this inhibitor. The meaning is if more substrate is available, then it can displace this inhibitor and the enzyme, the substrate can bind to the enzyme. So if substrate increases, okay, then function of the enzyme also increases, okay. So that is known as increased Km, okay. So in competitive inhibition, Km is increased, okay. So in competitive inhibition, Km is increased. That is, if substrate is increased, the speed of the reaction also increases, okay. That is what is meant by that, okay. But it is not the case of non-competitive inhibition, where even if you give increased substrate also, because the models are different, so it has nothing to do. So this remains same, okay. So now repeat with me what happens in to Vmax and this one, okay. So Vmax and we have Km, okay. So what happens in non-competitive, what happens in competitive, okay. So in competitive inhibition, what happens to speed remains the same because model is everything the same, so this remains the same, okay. And here what happens to Vmax decreases. Why? Because the model of the car is different. What happens to Km? If we give more fuel, more efficient fuel, then yes, very good, then Km increases because its efficiency increases, the engine efficiency increases with more substrate, okay. And what happens in non-competitive? It remains the same because there is nothing to do, okay. So now you will not forget, just with the help of this simple diagram, okay. Now we'll never forget what happens to Km and what happens to Vmax, okay. So we'll see one more graph which again students get confused frequently, that is what happens to graph, which are the two different type of graphs and which stands for competitive and which stands for non-competitive, okay. So in competitive, what happens? See, in this graph, you just see this is the velocity, that is Vmax graph, and this is the substrate, which is nothing but Km graph. Okay, so substrate is nothing but Km. You just remember like that. Okay, so now what happens in what happens to Vmax? You know, yes, Vmax remains same way, same speed, same model, same type of car. Yes, very good. It is competitive type of inhibition. So in competitive inhibition, the same, that is with inhibitor or without inhibitor, the same Vmax is at on the x-axis, that is on the axis of Vmax. Okay, that is velocity axis. So this graph which intersects on x-axis is graph for competitive inhibition. Okay, see this same type of model of the car. Okay, so Vmax is the same. So if V is same, it intersects on x-axis, then that means that the graph is for competitive inhibition. Now if the graph intersects at y-axis is what? 1 by s. So 1 by s is nothing but Km. So Km is same in which one? Km is same on in non-competitive inhibition. Yes. So if graph intersects on x-axis, okay, then that means it is for non-competitive inhibition. What are the examples? Examples are simple. For clinical, competitive inhibition, folate, see, this is DHFR. DHFR is dihydrofolate reductase enzyme, which metabolizes folate. But instead of folate, which drug has come? Methotrexate. So methotrexate is the competitive inhibitor of DHFR. Okay. Now similarly in non-competitive inhibition, you see here which enzyme is this? This is ALA dehydratase enzyme, and original substrate is ALA. Okay, that is amino levulinic acid. But what is inhibiting here? Lead. Lead is inhibiting this enzyme. Okay, so this is an example of allosteric inhibition or non-competitive inhibition. Okay, so I think I have okay. There's one more fact in this, that is one is mixed. Okay. Mixed means there is both competitive inhibition type also and non-competitive also. Okay, so in this case both will change. Vmax will also change, Km will also change. Okay, you know that in competitive what doesn't change? Vmax remains same, Vmax doesn't change. And what happens in non-competitive? Non-competitive Km doesn't change. Okay, but here in mixed inhibition both change. Okay, and second is in case of some irreversible non-competitive, there is permanent bond between enzyme and the inhibitor. Okay, so that is covalent bond. So in this case it causes irreversible inhibition. Okay, there is something called as irreversible inhibition. Okay, so let's go to the question. So there shouldn't be any doubt from now on. Okay, so what is the site of binding for non-competitive inhibitor? Yes, it is allosteric site. Okay, now structural resemblance, competitive inhibition structurally resembles the substrate. Okay, next, what is the effect on Vmax? Yes, very good. Vmax means the speed. If the model of the car is same, if the substrate is same as that of inhibitor, okay, if the structure is same, then speed is also same. So in competitive inhibition it is unchanged. In non-competitive inhibition, what it was, there is an allosteric break in the car. That means this decreases. So Vmax decreases in case of non-competitive inhibition. What is the effect on Km? Km means what? Km is nothing but Km is that extra efficiency of fuel. Okay, so in competitive inhibition where same model cars are running, if you give better efficient fuel, yes, Km increases. Whereas in non-competitive inhibition it remains unchanged. Okay, so I think there shouldn't be any doubt from now onwards. Okay, can be overcome by increased substrate? Yes, competitive inhibition can be overcome, but non-competitive inhibition cannot be overcome by increasing the substrate. Now what happens in the graph, that is known as Lineweaver-Burk plot. Lines intersect on x-axis for x-axis means which one? Substrate. Substrate means Km. Km is unchanged in which one? Yes, very good, in non-competitive inhibition. Okay, so here what happens in competitive inhibition, where what happens? Competitive, what is same, what doesn't change? Yes, very good, Vmax doesn't change. So Vmax in the graph, which is Vmax? It is y-axis. So yes, it intersects on y-axis. Now which type of inhibition is this? This is reversible competitive. This can be reversible, and if there is a covalent bond formation, then it is irreversible. Okay, next, drug showing same Vmax but increased Km. Which type of inhibition? Yes, yes, same Vmax. So speed is the same. So model of the car is same. So competitive inhibition. Very good. Allosteric binding site is non-competitive inhibition. Yes. So I think I have made it very simple. I don't think anyone would have made it so simple. We'll go to next thing, that is what is the significance of first pass metabolism. Okay, so first pass metabolism means whenever you give any drug through oral route or enteral route, except IV route, okay, it goes through the liver. Okay, any drug given through oral enteral route passes through the liver through the portal vein, and in the liver some amount of drug gets extracted. Okay, that is because liver metabolizes the drug. This is known as first pass metabolism. Okay, so liver is a site of first pass metabolism. Now what happens is, say any drug you give by oral route goes to the stomach, then it goes to intestine, from there portal will carries to liver. Here in liver there are enzymes which metabolize this drug, so only a fraction of the drug only reaches systemic circulation. Okay, this is for enteral route of drug administration. So what happens is, in the liver, as soon as this drug come, okay, let's say some 100 drug molecules have come, out of that maybe only some 50 or 60 only reach the systemic circulation. Okay, rest all is metabolized. So this is known as high extraction. Okay, E stands for extraction, which means liver is extracting lot of amount of drugs, it metabolizes it and releases less into the circulation. Okay, less amount of drug. Now what happens in the case of lipophilic drugs? Lipophilic means which have increased tendency to go into the cells. Okay, because cell membrane is lipophilic, no? So these molecules go into the cell membrane. So what happens in case of lipophilic drugs is they go into the liver cells, so they are metabolized easily, so there is increased metabolism. In addition to that, if there is high blood flow to the hepatic hepatocytes, okay, that is liver blood flow is increased, hepatic blood flow, then also there is increased metabolism. So in a way, these lipophilic drugs are dependent on liver blood flow, that is hepatic flow, for their first pass metabolism. So these are the drugs which have very less bioavailability. Okay, very less bioavailability. So this extraction ratio is, suppose there are like C in, that is concentration of drug inside is some 100, and then systemic outflow is there is only let's say some 20% that is going out. Okay, so the extraction ratio is how much? 100 minus 20 divided by 100, that is almost equal to 80%. Okay, so anywhere it is more than 70%, then that means that there is high extraction ratio. So in those cases we should avoid oral route, we should use IV route. Okay, IV route or IM route. Okay, or we can use one more route, that is through oral only, that is known as sublingual route, because the sublingual route the drug directly goes into the systemic circulation, it doesn't go through the portal vein. Okay, so you don't intake the drug. Okay, you just keep it below the tongue. This is true in case of nitrates, like in case of angina, where let me change the color of this. Okay, in case of angina where okay, this is also not a good color. Okay, in case of angina where drug has to go into systemic circulation, we don't want a lot of first pass metabolism, so we give it by sublingual route, and then because of this we'll have quick effect also, and there won't be any first pass metabolism also. Okay, one more drug which has very high first pass metabolism, that is propranolol. Okay, propranolol, we'll see in the examples how it is significant. Okay, third drug is a calcium channel blocker, which is verapamil. Fourth is morphine. Morphine also has high first pass metabolism. Fifth is chlorpromazine, which is an antipsychotic. Then we have lidocaine, which is local anesthetic, and testosterone. Okay, so these are the examples of drugs with high first pass metabolism, but you should at least remember this nitrates, and you have to remember beta blockers, these two drugs. Okay, next, atenolol doesn't has high first pass metabolism. Okay, so it has low first pass metabolism. Propranolol has high first pass metabolism. Okay, see, propranolol has high first pass metabolism. Second is what happens in rectal route is, in rectal route only lower rectal vein goes into systemic circulation, that is 1/3. 2/3, that is upper rectal vein and middle rectal vein, they drain into portal vein. So in rectal route there is actually partial bypass of that is first pass metabolism is there partially. Okay, so lower 1/3 bypasses, upper 2/3 goes to first pass metabolism. So there is only sublingual route which has completely systemic circulation and no first pass metabolism. Okay, next, naloxone is an important medication which has near complete metabolism, 0% with 0% bioavailability. So naloxone is not given through oral route. Okay, next, what is the clinical significance? Let's say in cirrhosis. Okay, in cirrhosis what happens? There is increased bioavailability. Why? Because liver is damaged, there is not much of enzymes left in the liver, so in first pass metabolism is decreased, as a result of which increased concentration of drug is available in the systemic circulation, so that there can be increased toxicity of the drugs in case of cirrhosis. Okay, so next we'll go through the questions. Okay, yes, which beta blocker has high first pass metabolism? Very good, yes, propranolol. Okay, Next, nitrates, which one? Which nitrate is used by sublingual route? Nitroglycerin, NTG we call it, okay. Verapamil is a calcium channel blocker which has high first pass metabolism. Which opioid has high first pass metabolism? Yes, very good, morphine. Which antipsychotic has chlorpromazine? This is an antipsychotic which has high first pass metabolism. What are other examples? Lidocaine or lignocaine and testosterone, okay, testosterone. So first pass metabolism extraction ratio is E. So high E means it cannot be given by low oral route, because through oral route there will be high first pass metabolism. Okay, so you have to avoid oral route which have bioavailability of first pass metabolism, that is the extraction ratio of more than 0.7 or 70%, more than 70%. Okay. Next, naloxone is ineffective orally because it has high first pass metabolism. Okay. Next, drug ineffective orally due to high hepatic metabolism. Which are these drugs? We have seen above. All those drugs which are given above are ineffective through oral route. Okay. Example is naloxone. Okay. NTG. Okay. Why nitroglycerin is given sublingual? Because it has high first pass metabolism and hence low bioavailability. Highly lipophilic plus high hepatic flow will have high first pass metabolism. Okay. So extraction ratio will be high. Okay, so in case of liver cirrhosis, what will happen is there will be increased bioavailability. High extraction drugs depends on liver blood flow. Low extraction drug depends on enzyme activity. Dose reduction is required in liver disease for high first pass metabolism. Plus all these things I have told you. Also one thing, propranolol shows marked increase in bioavailability in cirrhosis. Okay, so why do we give propranolol in cirrhosis? That is to prevent esophageal varices bleeding. Okay, so that's why we give propranolol. Okay. Okay, so we'll go to next topic, that is dialyzable versus non-dialyzable drugs. Okay, so dialyzable versus non-dialyzable drugs, there are certain properties which you need to know whether the drug is dialyzable or not. Okay, so we'll go through this. Whatever is in green are dialyzable and whatever in red is non-dialyzable. Okay, so first is depending on the size, very easy. This is the dialysis machine, okay, where you'll have dialyzable membrane and there will be some pores in this. Okay, so small molecules can pass through the pores. Okay, so first is the size of the pores. If the molecular weight is less, okay, that is the size of the molecule is small, then these small molecules will pass and they are dialyzable. Okay, so here we have this one, that is less than 500 daltons. Okay, less than 500 daltons. Okay. Next is second is protein binding. If protein binding is more, okay, the free drug is not available in the blood, so there is no point in dialysis. Okay, so if it is less than 80% protein bound, then it is mostly free and hence dialysis will work for this. Okay. Third is what is the volume of distribution. 2-3 slides before this I had discussed what is VD, that is that is volume of distribution. If volume of distribution is less, that means most of the drug is in the vascular compartment, that is in the blood only, so this drug can be filtered. Okay, so that's why most of the blood is inside the blood vessel, so it can be filtered. In case of high volume of distribution, like we had discussed, like digoxin, which had very high volume of distribution. Okay, so here the drug goes into the tissues, into the muscles, into the ECF, so more drug is not available in the plasma or in the blood, and hence there is no point in dialyzing this. Okay. Fourth is lipid solubility. If it is hydrophilic, it is mainly present in the blood and the extracellular fluid, which is again dialysable. But if it is lipid soluble, it is trapped in the adipose tissue and in the other tissues. So hence it is not dialysable. Okay. And some examples which you need to know. The gold standard example best is lithium. How to know? Lithium is has atomic number of 3, very less. It is a very small molecule. Okay, only 3 protons and 3 electrons are there. So lithium is one which has very small cells and hence is easily dialysable. Now why we are talking about lithium? Because lithium has very narrow therapeutic index. Okay, so even slight changes in dose can cause toxicity. Okay, so that's why lithium is one good news, that it is dialysable. Similarly, second is ethanol. Okay, ethanol causes severe metabolic acidosis. Okay, so and also salicylates also cause severe metabolic acidosis in case of toxicity. So these both can be dialysable. Okay, again a good news. Third, next is metformin. Metformin is also dialysable because metformin is a small molecule also, and secondly, metformin in metformin toxicity, lactic acidosis occurs. Okay, and this lactic acid is also dialysable. Okay, so it is good news for us. Which are not dialysable? First thing is digoxin. Why digoxin? Because it has a high volume of distribution. Second is TCA, that is tricyclic antidepressant. So in antipsychotic overdose, we can't do dialysis because they have increased volume of distribution. Third is warfarin. Why warfarin? Warfarin has a high protein binding. Okay, there is high protein binding, so that's why warfarin doesn't get dialyzed. So these three are dangers. We are not happy if patient comes with the poisoning in those cases. Okay. Now, what is the hack? One is if volume of distribution is less than 1 liter per kg, then they are dialyzable. Okay, 1 liter per kg. Okay, not total volume. Okay, so last time when I had told you what is low VD, medium VD, and high VD, it was less than 10 to 20 and 20 to 40. Okay, that was the total liters in terms of liter. Okay, this is liter per kg. So if the VD is less than 1 liter per kg, then it is dialyzable. Okay, next, if protein binding is not more than 90 or in some cases more than 80, it is non-dialyzable. Example cases warfarin. Now in lithium toxicity, I told you, no, lithium has very narrow therapeutic index. So that's why in case lithium value goes more than 4, then it is an indication of dialysis. Okay, serum levels of lithium. Now what is flux? Flux means it is the size of the pores. Okay, so if you increase the size of the pores, some larger molecules can also be filtered, like vancomycin. Okay, so it can partially be filtered. So if you have high flux machine, that is high pore size machine filter, then you can actually dialyze vancomycin also. Okay, so let's go to the questions. So low molecular weight is less than 500 Dalton, which are dialyzable. Protein binding less than 80% are dialyzable. Less than 1 liter per kg, volume of distribution is dialyzable. Lipid solubility, if it is lipophilic, then it is not dialyzable. Okay, it cannot be dialyzed. Next, examples are lithium. Okay, lithium for dialyzable drugs. Next, one important thing is, yes, theophylline. Theophylline is only partially dialyzable. Okay, it is not completely dialyzable. Then yes, next we'll go most dialyzable small molecule is lithium. Okay, next, drug with huge volume of distribution not improved by hemodialysis, it is TCA and it is digoxin. Okay, hemodialysis for salicylate toxicity indication is when the drug level reaches more than 100 mg per dl or there is presence of metabolic acidosis. Okay, next, lithium toxicity dialysis if values are more than 4 milliequivalents per liter. Okay, so if VD is more than 3 to 5 liter per kg, we are told less than 1, then dialysis. If it is more than 3 to 5, then we can't dialyze, it is never dialysable. Okay, and next, if protein binding is more than 90%, then also it is not dialysable. Okay, so I think I have discussed everything regarding dialysable and non-dialysable drugs. And next we'll go to a very important topic again, that is therapeutic drug monitoring. There are certain things in therapeutic drug monitoring which are actually asked more in INICET exams and recently in NEET also. So we'll have to go one step further, not just which are the examples, we'll have to know something else also, which I'll be telling you. Okay, so what are the examples? We'll see through the visual mnemonics only so that you don't forget it. So what is therapeutic drug monitoring? So there are drugs which have a narrow space between toxicity and ineffectivity, which means the levels at which the effect of the drug is seen and the levels at which the drug becomes toxic, the gap is very narrow. So these very narrow range, you will have to monitor the drug continuously because slight less causes ineffective drug therapeutic value and increased dose causes toxicity. So these drugs are mainly ones which have high pharmacokinetic variability, which means if you give to that one person A to a person A, the effect can be less, but given to person B, it can lead to toxicity. So there is high variability in the pharmacokinetic. So that is because of narrow therapeutic index and a non-linear kinetic, means some drugs like phenytoin, which have higher at lower concentration follows first order, but higher concentration follows zero order. Okay, so these type of drugs all require therapeutic drug monitoring. Okay, so we'll see some examples. So like for example, first one is phenytoin. Okay, so phenytoin, carbamazepine and valproate, they have different pharmacokinetics. Okay, so they switch between zero and first order kinetics, like as in the case of phenytoin, their bioavailability is also affected. Okay, and in case of carbamazepine, for example, where there is auto induction. Okay, so there are various things that causes the drug levels to increase and decrease within and that safety range is very low. Okay, So that's why these drugs, these three anti-epileptics, phenytoin, carbamazepine and valproate, these three require therapeutic drug monitoring. Similarly, in the case of antibiotics, for two antibiotics which we are concerned, aminoglycosides and vancomycin, because both of them actually causes a nephrotoxicity. Okay, aminoglycosides are gentamicin and amikacin, and vancomycin, these we never combine these two because there is increased risk of nephrotoxicity. So in case of aminoglycosides, we see something known as peak and trough. That is, peak means what is the highest value and trough means which is the lowest value. Okay, but in case of vancomycin, this is a new update. You don't see peak and trough. What we see is, we see something known as AUC divided by MIC ratio. Now, what is AUC? Area under the curve. So the area under the curve is AUC, and MIC is minimum inhibitory concentration. That is a antimicrobial property of that drug. Okay. So if this ratio is more than or equal to 400, that means more than 400 means the drug is going to act properly. Okay, which means therapeutic effect is achieved. If it is less than 400 means the therapeutic failure can occur. Okay. So we have other examples also, like immunosuppressants. In the case of tacrolimus and cyclosporin, both again have very narrow therapeutic index. Similarly, psychotropic, that is antipsychotics like lithium and clozapine, both need monitoring. We saw no last that if lithium goes more than 4 milliequivalents per liter, then we'll have to go for hemodialysis. Similarly, this clozapine, actually in refractory psychosis it is given. Okay, in refractory cases, this clozapine like can cause toxicity, like you are giving very high dose, and that can reflect in the form of agranulocytosis. Okay, agranulocytosis is a side effect. That is, you have decreased WBCs, that is decreased neutrophils. Okay, so that's why this clozapine has a low therapeutic index. Okay, similarly digoxin. Now what happens in digoxin? In digoxin, you know that it has high volume of distribution, so the drug levels, they distribute in peripheral system. Okay, that is in the muscles, in adipose tissue and all. Okay, so if you immediately take digoxin level, like you are suspecting there is digoxin toxicity, if you immediately draw blood, you won't find proper levels, because after you give a dose of digoxin, it will take around 6 to 8 hours to distribute in all tissues, and you will end up having false results. That's why in digoxin we wait for 6 to 8 hours. Okay, this was a question asked once. For digoxin we wait 6 to 8 hours after the drug administration to look for like therapeutic drug levels. Okay, and then theophylline again has narrow therapeutic index. Warfarin also has narrow therapeutic index, but we can't measure warfarin levels directly, so we measure INR. Okay, so if we keep INR between 2 to 3 pt INR, then that is the safety level. Okay, now digoxin, I told, wait 6 to 8 hours after the dose is given, last dose is given. In aminoglycosides, you see peak and trough. Okay, that is the highest value and the lowest value. In vancomycin, you see AUC by MIC. Okay, and in warfarin, you see for INR. Okay, and next, I think I have covered almost everything. Okay, we'll go to the questions now. So these are the examples which we have discussed. Everything is there in this. Okay, so you don't have to go again. New therapeutic drug monitoring is emerging for one antibiotic, that is linezolid. Okay, in linezolid it was observed recently, this is a recent update, that some hematological parameters were deranged. Okay, so that's why linezolid is a new drug which has got therapeutic drug monitoring. Okay, next, vancomycin, AUC by MIC is more than 400 means therapeutic levels have reached. Okay, here we have one more drug, which is this drug clozapine. Okay, clozapine. Antifungal, you have voriconazole. You can remember how much ever you want, but I will suggest whatever is given in the image, no, just remember that, voriconazole. Okay, next, warfarin itself is not TDM measured, effect is monitored by a PTINR, because we can't measure warfarin levels directly, that's why we use PTINR to measure. Okay, next we'll go through clinical trials. Okay, so next, going to stages of clinical trials. So there are total 5 stages from phase 0 to phase 4. We'll see it one by one with the help of visual mnemonics. So phase 0 is exploratory phase, where what we do is we give micro dosing, a very small dose. Okay, Microdose. Basically what we want to see is how the drug acts, okay, that is via pharmacokinetics and pharmacodynamics. It is tested on a very small group of patients, and we see how the drug acts. Actually, we are not concerned whether the effect of the drug is there or not, whether it will cure the disease or whether there will be adverse effects and all. We just want to know what is the pharmacokinetics and pharmacodynamics of the drug by giving a very small amount of drug, okay. That is nothing but phase 0. After this comes phase 1. Phase 1 is where we'll see the safety, okay. So this is exploratory and this is safety, okay. So here we take healthy volunteers, not sick patient. We take healthy volunteers and we assess what is the safety of the drug, okay. So we see two parameters. One is MTD, another is DLT. So MTD and DLT. DLT means dose limiting toxicity. So dose limiting toxicity means the dose above which we can't increase the dose further because toxicity features will appear, okay. And MTD is maximum tolerated dose, okay. So what is the maximum dose at which adverse effects don't start, okay. So these two parameters will check. Once the drug is approved for this, then it will go to phase 2. In phase 2, what is the question that we ask? Does the drug work or not? So what we do, we find its efficacy, okay. So we find its efficacy, and for efficacy we want to try not on healthy patients, we want to try on patients, okay, that is those who have disease. Then we find what is the dosing optimal. We find what is the most effective dose, okay, that is we find effective dosing. And this phase 2 has two components, that is phase 2A and phase 2B. Phase 2A is proof of concept, which means you will have to prove, the drug company has to prove that. So phase 2A is a proof of concept, which means the drug company has to show that this drug is effective, okay, that is it has to show the proof. And second is they have to find what is the optimal dose, what is the best dose at which the effect takes place, okay. Then comes phase 3. In phase 3 what we see is whether the so here we will compare the available drug with the prior drugs, with the standard drug, and see whether the effect of this current drug is better than or like what is the standard, okay. So is this drug better than the other drugs that are available in the market? So here you will list to a large amount of patients, that is okay, a large multicentric patients, and then you compare whether the standard is better or not, okay. And this is the place where highest budget of a drug company goes into. And phase 4 is post marketing surveillance, where after release into the market we'll be going to see adverse reactions that are going to occur. And this is the main reason, because of this serious rare adverse events that can cause withdrawal of the drug from the market. So it is during phase 4, not during phase 1 or 2 or 3, that there is a highest chance for drug withdrawal, okay. So you can see like give a mnemonic, that is sex, that is SSECS. Safety, that is one is microdosing, phase 0, okay. And S is safety, E is for efficacy, C is comparison, and S is for surveillance, okay. Okay, so okay, that's it. So we'll go to the question answer session, okay. Okay, so microdosing, that is we see pharmacokinetics and pharmacodynamics, and for this we use a very small population, okay, very small population. Phase 1 is what? To find safety of the drug, okay. We use healthy volunteers. Phase 2 we see efficacy and we see dose finding, and here we use patients, okay. Phase 3 is all about comparison and standard, and phase 4 is about post marketing surveillance. At phase 1 you will find what? MTD and DLT. What is MTD? MTD is maximum tolerated dose, and what is DLT? DLT is dose limiting toxicity, okay. What are these? I have told you in the image just now. But end of second phase you have proof of concept, that is the drug works, and second is we'll find the optimal dose. Third is to find whether the efficacy is better compared to current standards, and fourth is to detect rare adverse drug reactions. Phase 2B is what? Phase 2B is to find optimal dosing, okay, optimal dosing. Next, phase 4 is not RCT, remember, phase 4 is post marketing surveillance for rare side effects, okay. And one more thing, oncology trials never use healthy volunteers, okay. Remember this thing, we saw that in phase 1 healthy volunteers are used except for oncology drugs, that is for chemotherapy drugs we don't use healthy volunteers, okay. Phase 0 is what? Phase 0 is microdosing, it is not related to safety. Phase 0 is related to microdosing. Okay. Next, identify trials assessing efficacy in patients. So which phase assesses efficacy in the patients? Yes, very good. Phase 2b. Phase 2b is for efficacy. Okay. Which phase detects phase 2a? Sorry. Okay. Phase 2a. Phase 2b is for optimal dosing. Which phase detects rare adverse events? It is phase 4. Okay. Okay. So I think we have covered almost everything. Okay. Now we'll go to next topic. We have finished general pharmacology, and now we'll start with the autonomic nervous system.